one of the doctor in the clinic today. Can I please confirm your name and age, please?
Yes, doctor. I am Nadia Farouk.
In the scenario, it was given like I'm speaking to the sister or patient directly.
Yes, yeah, no, you can talk to the patient himself. You can talk to the patient himself, okay, herself.
So this is Nadia, 48 years old, correct?
Yes, yes, doctor.
So I understand that you have a headache. Is that correct, ma'am?
Yes, doctor. Today, while I was in the kitchen, I suddenly
Mhm.
developed severe headache. So my husband calls the ambulance, and they bring me here to the hospital to see what's wrong with me.
Okay, I can understand, ma'am. I will be taking some notes and I'll try to help you as much as possible. So would you like any
Thank you.
painkiller now? Are you able to bear with the
Uh,
pain or can we can?
After we finish, doctor, you can give me.
Okay, I'll offer her some painkillers.
Okay.
Okay, so you said it started suddenly, correct?
Yes, suddenly, doctor.
Okay, so how bad do you rate the pain? Like from 0 to 10, 0 being a very nothing, 1 being a very mild pain, and 10 is the worst pain in your life. What number would you give to this?
Yes, doctor, this is very severe. I can score it at least 8 or 9.
Okay, I'm so sorry to know this. And where
Thank you.
exactly can you please show me the site? Where exactly is the pain?
Actually, doctor, it is over my head, but especially more severe on the back of my head.
Okay, is this the first time you had like this?
Yes, doctor, the first time.
Is it the is this the worst headache that you ever suffered in your life?
Before I have headache, stress headache, and take paracetamol, and it go by when I take the paracetamol, it relieved. But now it is very severe, doctor, and not relieved when I take paracetamol.
Correct, but categorically, is this the worst headache that you ever suffered in your life? Just wanted to be
Yes,
sure.
yes, yes, doctor.
Okay, I'm in. Okay, so I'll be a little quick here. So, do you have any other weakness?
Weakness? No,
Weak?
doctor.
Do you feel any in your body?
Feel what?
Any weakness in the body? Do you feel?
No, no.
No. Okay. Any vision problems at all?
Vision problem? Yes, my vision, I feel blurred slightly, doctor, from the today morning.
Okay, and this goes with the headache, correct? Same
Yes,
time.
I think yes. Yes.
Okay. Any throwing up feeling that you have? Any sick feeling?
No.
Okay. Any like did you suffer any like shaking of the body or any fits like things?
No, doctor.
Okay. Any tummy issues at all that you have? Any tummy pain or anything?
No.
Any problems with the water work?
Uh, no.
Have you ever seen the water works are little dark or anything like that?
Before, doctor, but after treatment, I have been very well.
When you say before, what do you exactly mean by that?
Actually, doctor, I was having before I put a disease in my kidney. I was having kidney failure, and they replaced my kidney by a new one.
Oh, okay. So can you tell me what was the condition and when was it replaced?
It was about 1 year back, and they told
Uh-huh.
me I have sacs in my kidney.
Okay, understand that. And when was the surgery done?
1 year back.
1 year back. And
Hmm.
after the surgery, how was it? How were you coping with the surgery? Like, how was the?
Yes,
Did you
I
follow up regularly?
yes, I usually go on regular follow-up with the transplant team, and they give me medication, and I usually on regular follow-up.
Okay. And what are the medication lists? Can I see your list?
Yes, they give me a medication called tacrolimus, and
Mm-hmm.
other medication called prednisolone,
Mm-hmm.
and just this. Yes.
Okay. Going back to the headache again, do you think that the headache is increasing on coughing or anything on leaning forward?
Yes, right, doctor. When I cough, it increased so much.
Okay. And how is it relieved? Like pain? Have you tried anything?
Uh, yes, I tried. I told you paracetamol, doctor, but I got two
No.
tablets, but it doesn't work.
Okay. Any other medication you're taking over the counter or anything like that?
No. When I find this, my husband calls the ambulance and I come here.
Okay. The transplanted kidney, which you said you are following routinely, correct? Am I correct in
Yes.
that?
Yes,
When was
doctor.
the last checkup that you had with the doctor?
About 1 month. In the last month I go, and he said to me it is working well.
Okay, no worries. Moving on. Do you have any chest discomfort, like any chest
Chest?
issue?
No, no,
Uh-huh.
no,
Difficulty at all?
no,
Any racing, pacing of heart?
no. No.
Okay. Any tummy, like any hard stools or loose stools?
No, my bowel work is okay.
Okay. Any problems with the joints?
No.
Any skin rash at all?
Skin rash? No, doctor.
Yes.
No.
Can I know your family history? Like anything significant for me?
Yes, my father also was having a similar problem. He was also end by dialysis, no transplant at this time.
No, he also transplanted. Okay, understand. Anything else?
Yes, my mother was having rheumatoid and thyroid issue.
Okay. I'll be asking some personal questions. How is your periods,
Okay.
man?
My period? My
Yes,
period, yes, doctor, my period is okay.
the regular. Are you on any birth control pills?
No, no.
Okay. Do you have a regular partner?
Yes, I am married and I have 3 kids.
Sorry to ask you, any casual partners?
No, no, doctor.
Okay. Do you do any smoking, alcohol, anything like that?
Yes, I smoke.
How many cigarettes is that?
About not much. About 8 cigarettes in the last 10 years.
Okay. And what about alcohol, ma'am?
Yes, occasional on social level.
Okay. Do you drive at all?
Yes, I drive sure.
For now, I would advise you to stop driving before we get into the deeper things. Is that okay?
O- Okay,
What do
doctor.
you do for a living, ma'am?
I am an accountant.
And how is this all affecting your life?
Yes, doctor, I cannot
Yes.
withstand this pain and I cannot go
Yes.
to the work today
Yes.
because of this pain.
True, true. I'll address that and I'll try to give a sick leave or something like
Thank
that.
you.
Okay.
Thank you, doctor.
I would like to examine the patient.
Okay, what do you want to examine?
So I will examine her hands first. Like I'll check any peripheral signs of any signs like pallor, any clubbing,
When
any
you
active
you see like
uh-huh.
this.
So when I see the fistula, I'll check for the thrill. How is it? Any thrill and
Yes,
is there an active fiber marks?
fistula, yes, functioning but not recent used, no recent needling.
Then immediately I look for the neck. Any central line
Ah,
placed.
yes, there is a scar. No, no central line, but scar for previous tunnel line.
Okay, I would like to ask the patient when was the last dialysis?
No, doctor, the dialysis was before before the transplant. No, no, not
Correct. But
after. Yes,
but this fistula is still active. That's what you said, correct?
yes, it is active but not recently used.
Not recently. Okay. Then I'll check for the pulse.
Pulse as outside, it is 100 and regular equal both sides.
Okay. Then I'll check her eyes for any pallor, conjunctiva for any jaundice, mouth, any oral cavity. How is the oral hygiene? Any ulcers? In the
Ah,
neck, I will check for the lymph nodes, thyroid swelling quickly.
okay, type. And nothing in the neck except the scar. In the mouth also. Anything else in the mouth you'd like to see other than the ulcer?
The gum hypertrophy or anything because of the drugs.
Okay, yes, gum hypertrophy present also. And in the eye, you are looking for pallor and jaundice negative. Anything else in the eye?
Any edema, peripheral, like periorbital edemas,
No, negative. What
fluid
else?
overload, some overload, anything.
Any what? Fluid overload? Where?
Yeah. In the around the
Where?
eyes,
No.
nothing. Okay. Coming back to the I think we are in the neck, right? Neck is done. Any lymph node enlargement?
No lymph node. What else?
And and in thyroid gland, any swelling?
No thyromegaly. What else?
You told me about the central line and scar.
Scar, but
JVP?
no central line. No central line, only scar.
Any JVP raise or anything?
Not raised. What else?
Okay. What else in the neck?
Hmm.
What else in the neck?
What
Neck,
else?
neck, neck.
Where?
Bruit. I'll check for the bruit.
Berui? No need. No need.
What else? What else, doctor? I'm thinking
It's
APKD reverse.
not a neck anywhere else. Not a neck anywhere else. 2 minutes
Yeah,
remain.
chest.
Yes.
Examine the
For what?
chest for any
For
added sounds or something, fluid overload, added sounds, basal clefts.
negative. Negative. What
Any
else?
cardiovascular, anything? Any sounds?
You are looking for what exactly? Say what you are looking for. Which sign?
Like I'm looking for any murmurs or any flow murmurs or any fluid
No
overload.
audible. No audible murmur. Audible
Then
S1 and
immediately, then
Hmm.
I'll check the kidney, the scar or the abdomen, any scar. How is the transplanted
You see
kidney?
like this scar in the kidney. What else?
I, I'll do the palatability.
On the left side there is palatable mass. On the right, no.
The
What else?
scar, any local raise of temperature. How is the scar? Any
No.
temperature? Any
Scar
signs of
is very
infection?
down. No signs of infection or inflammation.
Okay. Any pedal edema, sacral edema?
No bipedal edema or sacral edema.
Okay. You said you had headaches before. So are you taking any painkillers regularly?
No.
Okay. Sorry.
Nothing.
That what I can.
Concern?
Yes.
What's wrong with me, doctor? Why I have this headache?
Yes, ma'am. Like having taken a history, what comes to my mind is there's a condition. Sorry to tell you this. This is something serious. I'm suspecting that is called a subarachnoid hemorrhage. Have you ever heard of this?
No, what is this, doctor? Is it serious?
Yeah, I will explain you. I'll put a diagram. I'll show her that there is a swelling of the vessel and it getting burst. I will tell her that it could be partly because of the condition which is having in your kidney. Are you able to follow me, ma'am?
Yes. What is this, doctor? What mean? Hmm.
So this condition, what you had, the sacs in your kidney, the adult polycystic kidney disease, this has many manifestations. One of the manifestation is like this berry aneurysm. I'll put a diagram, try to explain her. So unfortunately, this is happened to you. Yeah.
Hmm.
Any other concerns for me, ma'am?
Is it serious, doctor, or are you going to admit me?
Yes, yes. This is a it's like an acute emergency. We can't waste time, and we have to immediately admit you. And a multidisciplinary team will look into this. We have to immediately do some brain scanning and some test. Is that okay, ma'am?
Okay, doctor. Okay, thank you. Time up. Give me your positive finding in the history and examination in this lady.
So the 48-year-old female came with severe headache, sudden onset, back of the head, and worse pain in her headache, scoring 9 or 10 per day. And she has a previous history of SACS, probably polycystic kidney disease, which was operated, and then she's on immunosuppressants.
Hmm.
And history, the family history also is significant. And on examination, the patient is having active fistula. On examination of abdomen, there's a scar, there's a kidney, there's a transplanted kidney, and
Okay.
yeah. What else? Yes,
And
these were the signs, sir.
okay, doctor. And what is your differential diagnosis?
Uh, the first thing which will come into my mind is the subarachnoid hemorrhage, the headache,
Okay.
probably because of the underlying adult polycystic kidney recurrence
Okay.
in the
What else?
kidney, and that is a major diagnosis. And for the other headaches, I can consider. What else can we
Hmm.
consider? This is a very severe headache. It's a clear cut, but I would still consider some.
Hmm. Anything else?
This is very obvious. Any other headaches won't fit. But anyways, I can
Right.
tell maybe
Okay.
migraine.
What's your investigation and in this video?
So immediately I will do some brain investigations, which would include MRI and MRI at angiography. I will like to do ultrasound of the kidney. I would like to do the blood levels, urine electrolytes, and routine investigations.
Anything else?
Anything else? Anything else? Uh, Even to rule out any heart like aneurysms or liver aneurysms, I would do further testing.
Okay, Dr. Danish, thank you. Well done. Just a few comments regarding your performance. We will start by the most important. For my opinion, or my point of view, the examination. You have here headache, acute severe headache. Okay? And
Neurology.
yes, where is the pronator drift? At least, where is the? You asked it very good communication. I think you can get 4/4. I mean, satisfactory. No one will minus you. Very unlikely. But science, you examine the chest. What is the value of the chest here? Nothing. Immediately jump to the neuro, but just check the neuro. I mean, one test from each one. I cannot say for you make the whole neuro examination such as neuro because it takes at least 6 minutes. No, you will make, for example, at the elbow joint, you will make the tone or power. Okay, you can make pronator drift or you can make Babinski. One of them, just one of them. Okay, just one of it. Where is the neck stiffness for meningitis and also for the subarachnoid? At least you should make neck stiffness. Okay. It's very important. The other important, this patient told you I have eye or vision problem. Where is the examination of visual acuity and the fundus and the field? Must. Any headache must do the visual acuity, at least by your finger, no Snellen chart. Do you see my finger? Yes. How many fingers? 2 or 3. Other eye? Okay. Immediately the field. Immediately H-shaped, because in this case, you can suspect also there is third or fourth or sixth cranial nerve. You must examine at least H-shape. No. Okay. And if you have just a few seconds to check the sensation of the face, even by your finger, compare both sides in the both 3 areas of trigeminal nerve. Okay. Very rapidly. And if you have time, open your mouth, check the uvula, say gag reflex. Okay. To check also for the last cranial nerve. Okay? 9 and 10. Okay, but no way vision must field, ask for fundus, papilledema must, in any acute severe headache. Okay, must. Neck stiffness must. Check neuro 111 must. Okay, then after you finish this, if you have time, jump to the abdomen as you did. You finish the abdomen very good for the adequate and for the scar and for palatable masses, very, very good. Okay, you checked for volume overload, very good. Under or insufficient kidney replacement, you check everything. Immune, as the abdomen case, any manifestation of immunosuppressive toxicity, hypertrophy or tremors, you can check. But this at the end. But to gain the mark, to gain the satisfactory, you must examine neuro, which means one test from each one, from the power, tone, reflexes, and then jump to the eye.
Because I was confused about diagnosis itself. Is it a recurrence? Is it an other headache?
No. So 1 minute. This under category, she has severe headache. In severe headache,
Correct.
is this a gift? Why it is a gift? And you see from outside, blood pressure is very high.
Correct.
Yes, you suspect from outside even more than 90% it is subarachnoid hemorrhage. Okay? Just the other, as a differential, to be a safe doctor, you will need to and this also you didn't ask pituitary apoplexy, just to check it, because the case of basis favorite. I know blood pressure is high, not adrenal insufficient, but you can ask, for example, if you have any nipple discharge before, if you have pumping interruption before, to just check the prolactin, and if do you have FSH problem, LH, I mean, if you have any period, no period problem, any problem in intimate relationship, no. Just 1 or 2 questions to show the examiner. I know it is not pituitary, but to show him that you are aware that number 2 is pituitary. Number 3, I think you didn't ask me about temperature for meningitis. Okay, meningitis, very important. Neck stiffness and fever must, because this is for the acute severe headache. What else? You didn't ask me about clot history. cerebral venous sinus thrombosis, CVST. You didn't ask about it. Cerebral venous sinus thrombosis. In history of blood clot, no doctor. In history of pregnancy loss, no doctor. خلاص, sufficient. CVST. CVST, take care because some candidates has confusion between the cerebral venous thrombosis, sinus thrombosis, and cavernous. Cavernous is something else. Cavernous, as you did, there will be edema of the face here, and there will be septic focus, for example, sinusitis or dental issue, and the edema of the face, and also must of ophthalmoplegia. His eye or her eye must not move, which means 3, 4, 6 paralyzed at least. This to say it is cavernous sinus thrombosis with or without any septic. So you must see eye not move. If you see this, okay, and the facial swelling, you can say cavernous sinus. Otherwise, if she has blurring of vision and the clot issue, thrombophilia, you can say cerebral venous sinus thrombosis. This one differential. What else in this, also in this area? The pregnancy issue, preeclampsia, no. Lumbar puncture, no. Okay, so we have this, the most important for thunder, clap, headache, or acute severe headache. Meningitis must be checked, and thrombosis issue must be checked. Okay, and what else? Subarachnoid hemorrhage. We have here subarachnoid hemorrhage, and as you said, the risk for, because she has ADPKD. Okay, and you check the, okay, you can check the heart at the end for mitral valve prolapse, no problem. But if I were you, I know from outside this headache equals neuro, that vision only. If you have time, you can check the other things, association or the cause, ADPKD, mitral valve prolapse. By no, they will not forgive you if you miss neuro or if you miss vision. Second point. Yes, so your defect here in the examination is the most important. Okay, if in the examination, if he benign examiner can give 2 out 4. If malignant examiner can -4. Okay, but this here to learn. I mean, I think if this case is very repeated, take care. طيب, another very important point to Dr. Danish, and also very basis favorite. This patient is taking tacrolimus. Okay, you know, and the blood pressure is very high. And sometimes also they told cyclosporin. But now the trend in basis about this tacrolimus, the eye on it, how? We have a new diagnosis called the Brest syndrome. You should know about it very well, which means posterior reversible encephalopathy syndrome. This sometimes tacrolimus induced. Okay, you should measure the level of tacrolimus, and comes with the like hypertensive encephalopathy. Mainly can come with headache as this, but the headache will be less severe. So in the differential, if I were you, I can set hypertensive encephalopathy. I can set Brest syndrome. I need to measure the level of tacrolimus. Why, doctor? To check if there is tacrolimus toxicity. And as you said, MRI brain, but not number one. Number one is CT to exclude or rule out stroke or hemorrhage. Non-contrast CT number one in any acute headache. Okay, this patient acute headache, you need to rule out. You said subarachnoid hemorrhage. Subarachnoid hemorrhage to diagnose it. Number 1, CT. Number 2, lumbar puncture. Where is the lumbar puncture? After 12 hours. Okay. Number 3, as you said, MRA. Okay, magnetic resonance angio or CT angio. Okay, but this is number 3, not number 2. Okay. Number 1, CT without contrast to rule out bleeding. Okay. Number 2, lumbar puncture for xanthochromia to rule out subarachnoid hemorrhage. What else, doctor? We can do MR angio, CT angio. Okay? So, Brest syndrome is radiological diagnosis by MRI. You will see posterior edema in the posterior part of the brain. When you correct the blood pressure, it is reversible. Hypertensive encephalopathy, similar to Brest, but usually there is target organ damage. Okay? Both of them refer to neurologist. Okay? And gradual control of blood pressure. There is a very famous case in your center and in UK, come with confusion, not acute headache. And when you ask the patient, it is about 55 or more than 50. The history of the patient, just he will say to you, I have hypertension since about 1 month ago, and they give me amlodipine, Okay, but actually I didn't take an amlodipine. And at this point, if you didn't ask like communication, why, what is the reason, they will minus you in the communication. They want to address the non-compliance of amlodipine. Okay?
Mhm.
And correct here, why is not type. Now he comes with confusion and the memory problem since about 1 or 2 weeks, not acute headache. And blood pressure from outside also you will find it high, very high, 160 or more, and diastole 100 or more. So the same diagnosis, it is Bres syndrome. Okay,
Yes.
posterior reversible encephalopathy syndrome. Okay, same.
Mhm.
You will, in this case, the same. Refer to the neurologist, do CT to rule out any CT, and then MRI to rule out bleeding and to diagnose the posterior reversible. Here, without any tacrolimus, this patient without end-stage renal disease. Sometimes the Bres syndrome come a normal patient without any kidney issues, and sometimes drug induced by tacrolimus as this patient. Okay, so don't forget Bayes' favorite Bres syndrome and its colleague, its brother, hypertensive encephalopathy, the same. Both must sit in the same differential. So if I were you in the differential order, they will minus you. Where is the differential? Here in the differential, you said only subarachnoid. Okay, less likely to be. Don't number 4. You can't say pituitary aplexy because less likely, as we said, because she has no any pituitary adenoma symptom. Type number 2
True.
may be Bres syndrome or hypertensive encephalopathy. What is the evidence? Maybe tacrolimus toxicity. I need to measure tacrolimus and do MRI on the brain to rule out any posterior reversible encephalopathy syndrome. This number 2 in differential. This number, if he said what else, meningitis is very less likely because no risk factor or
Yes.
no fever and no photophobia, or even if there is photophobia, no fever. We can rule out also when do the lumbar puncture. Okay? And pituitary
Okay.
aplexia, they will go to the number 4. But must hypertensive encephalopathy and the Bres syndrome number 2 after subarachnoid hemorrhage. Okay?
Okay.
Emergency. So everything you said, this is emergency case, acute case, and most likely in the basis you will have at least one acute case. You must in every step say urgent, urgent, urgent. I need to do urgent CT to rule out bleeding or stroke. I need to do urgently admit the patient and resuscitate him. Okay.
Mm.
Then in the treatment, when admit urgent CT, and when you confirm diagnosis of arachnoid, you will give her what? Correct blood pressure by nimodipine, calcium channel
Mm.
blocker, and colleagues in the neurosurgery to see if there is any clipping or any maneuver they can do to stop the bleeding and like get the bleeding vessel. Okay, this
Correct.
is the gold standard. In the basis, Dr. Danish, don't say sentences or paragraphs, say words, because if you take their paper, if you are the examiner, they will see in the calibration words like this: CT on the brain, urgent, MRI, urgent admission, and nimodipine, just words like this. They will not write paragraphs and when you see like this, in the judgment, you will take one satisfactory. Okay? Similar in the judgment, similar in the communication, similar in the differential. For example, here they written for sure subarachnoid number 1. Number 2, they will write, for example, Bres syndrome or tacrolimus induced. Number 3 for hypertensive encephalopathy, and 4 for less likely to be meningitis. For differential, for example, 3, 4 over 4 satisfactory. This is a professional way to address this exam and to get the high marks. Just words. Okay, you finish your time management is okay, but you need just rearrangement or adjustment in the examination
Exactly.
steps. Yes, examination and differential. Here, you should adjust even before you enter. This acute headache, I will jump to the neuro. I will jump to the.
Is a recurrence of the disease in the transplanted kidney?
Any recurrence?
Because the patient had transplanted, so this is a recurrence of the disease, or
No, no recurrence. She has ADPKD. You know, ADPKD is associated with what? Very aneurysm.
okay.
Yes,
Correct.
very
Okay.
aneurysm. Even you just treat the kidney. You
Yeah. Got it.
treat the kidney. Yes, but still she has aneurysm. No recurrence of the
Aneurysm.
disease. Okay?
True.
Yes, her kidney is. And this is your job also to see if there is fluid overload or no, negative. And you see this. As the kidney, as the renal case in the abdomen, to see if there is or there is a kidney transplant working or not, or sufficient or not, adequate or not, adequacy of the renal transplant or renal replacement therapy, and the immunosuppressive side effect. But this at the end, this is not our goal now. Our goal now to sort out why she has severe headache. Is it subarachnoid? Is it apoplexy? Is it meningitis? Is it cavernous sinus thrombosis? Is it Bris syndrome? Is it hypertensive encephalopathy? You got the point, Dr. Dinesh?
I got diverted. I was thinking about any transplanted kidney issue, so that's why I couldn't focus on the actual neuro.
No, transplant here is the second part of examination. As you did, you just put your hand on the scar. You just see if there is precipitation for adequacy, or for volume overload, and she is not volume overload and no manifestation of uremia. So this means that adequate renal replacement therapy. Okay, but the problem in the headache. ADPKD cause subarachnoid aneurysm. Tacrolimus cause Bris syndrome. No fever, يبقى less likely to be meningitis. No clotting, less likely to be cerebral venous thrombosis. Okay?
Okay, doctor.
I would
got it, doctor.
yes, jump to the eye, weakness, and the pronator drift and tomb power reflexes very rapidly. One test. Don't make like neuro every. You will not have time. Just at the elbow or at the deltoid, check the power and the tone. Just one of them at one joint, not two joints. Okay, and the pronator drift, for example, or Babinski, very sufficient because you take one test from each one. Then on the eye, shape the movement, visual acuity, fundus, okay, and sensation of the face and the uvula. So, شكرا كده, very good. Thank you. You got that?
Yes, 100% got it.
One, if we have top 10 scenario, I can put this from the top 5, not the top 10.
Yes,
okay?
Yes, doctor. Yes,
Type
doctor, got
support.
it.
Every scenario has its sub or versions. One version of this, I will remove this nice kidney. I will give you no transplant here. Okay? And no here, no previous dialysis. And just the lady come with, yes, doctor, I have, but you should ask, I have previously amenorrhea. Until now, I have amenorrhea, irregular cycle. Okay. You have headache, previous headache? Yes, doctor, I have headache, but it was not severe before. It was chronic headache. Okay?
Correct.
And
surgery and pregnancy and any excess blood loss.
Okay.
Apoplexy.
Anything else?
Like, yeah,
Sure,
excess
sir.
basically.
Say.
So I'm thinking in those lines, pituitary apoplexy, pituitary, basically that after that the symptoms started.
Yes, jump to the pituitary. If you have here a headache, okay, and this headache increase, and chronic headache, not acute headache. Now become acute, but before chronic headache. Suppose this chronic headache. In the chronic headache, this is another issue. You will divide your brain as we know. Is it increased by coughing, sneezing, and then forward or not? Okay, if it increased by coughing, sneeze, we have one of two options, nothing more. Okay, either specific occupying lesion or IIH.
Intracranial hypertension, yeah.
Yes, idiopathic intracranial hypertension. How you can differentiate? You can ask specific occupying lesion here, either also to pituitary or non-pituitary. Okay, usually in basis they will give the pituitary because it's related to us, not to the surgeon, to our medicine. So you will ask about the main or K hormones. FSH, LH, you will ask about what? Amenorrhea? It will be usually positive. Yes.
Problem with
prolactin, yes, nipple discharge, it can be positive, and she can say to you, yes, I take bromocriptine or bergolide for the blocknome. What else? We have still the ACTH. You can ask about the Addisonian or the insufficiency. Do you have any dizziness? You can give also, they can give from outside the blood pressure low in the apoplexy. Yes, TSH. Do you have any manifestation of hypothyroidism such as weather preference? Take care in this adrenal insufficiency, Dr. Dinesh, in this adrenal insufficiency, no tanning because no ACTH. Okay, unlike the Addison, yes, in the primary Addison, here in the suprarenal, ACTH is super high. So we have tanning. But when ACTH is low, no tanning. So you will find what we call alabaster skin. Alabaster skin. Okay.
Alabaster. Okay.
This patient can come with two options. Either acute, as this patient, it will be, as you said, adenoma, and this adenoma rupture to make pituitary apoplexy. Okay. The other option will come with chronic headache. Okay, and in this patient, this is still adenoma and not make apoplexy. In apoplexy, you will do the same workup as we said. You will do the CT or MRI pituitary. Okay, and then in adrenal insufficiency, you will replace the steroid by IV fluid, IV hydrocortisone, because it is acute adrenal insufficiency. Then also refer to neurosurgery for decompression. This in pituitary apoplexy very favorite in bases. No one can enter bases without pituitary apoplexy. Take care,
Okay.
admission, IV fluid, intravenous hydrocortisone, because this adrenal insufficiency. Neurosurgery for decompression. Okay, Dr. Dinesh?
Okay, doctor.
The other option become now less favorite in bases, which is if you didn't find all pituitary is negative. Okay? And maybe non-pituitary. Or maybe non-functioning. Pituitary adenoma. Yes, bumping. Or maybe giving you, this is the old scenario of bases. Obese patient has acne. Yes, taking tetracycline or taking steroid. So you will suspect IIH. And IIH, idiopathic intracranial hypertension, give me the culprit medication. Or
Vitamin A, tetracyclines.
No, I mean the treatment.
Acetazolamide.
Very good. Acetazolamide, which a carbonic anhydrase inhibitor, and then repeated what?
Repeated LPS. Lumbar punctures.
Yes, repeated drainage, lumbar puncture, and the gold standard is ventriculoperitoneal
shunt.
Okay, and if she has any vision issue, refer to ophthalmologist for decompression to save her. And for sure, in chronic, you will control her weight. Okay, this here, if you didn't examine the fundus and the field, same as before. Any headache, jump to the any headache, it's very clear. You must jump to the vision. Okay, headache equal vision. Headache equal vision. Okay, so this is the most common scenario in either acute headache or increased intracranial tension headache. The specific lesion, which is pituitary, and IIH, which is idiopathic intracranial tension. Other headache, we have still the last one, become less frequent now. In the last diet, it was frequent about 1 or 2 years back. Which is we have here chronic headache, but no ICT. I mean, no increase in intracranial tension. Yes. Medication overuse. This was the viral diagnosis about 1 or 2 years back. Medication or analgesic overuse a headache. After exclusion, you must exclude first the intracranial tension. Yes. And then tension headache also. And also you can exclude tension headache and any increase in the intracranial tension. Okay?
Okay.
Right. We still have two or other type of headache, which is recurrent headache. What is the recurrent headache? Yes, migraine.
Migraines, cluster headaches.
What else?
Yeah.
FEO. Under FEO, put 100 line. Type. The cluster, what is the culprit question? The cluster?
Yeah, nasal discharge, red ironing, one side of the face, predominantly males.
Yes, dropping of okay, very nice. And occur at the same time of the day in the cluster, and then give me the culprit medication and the prevention. In the acute.
Oxygen.
Very good. And the prevention, Vera?
We can give, I'm not sure. Propanolol?
Yes, verapamil is the best. Verapamil. Calcium channel blockers. Okay, type. Migraine. In basis wise, in migraine, you know, I think you know this. We have migraine and pheochromocytoma. In migraine, bases are focusing on one thing only, not two things, which is complex or hemiplegic migraine. He will give
migraine.
you, yes, patient, young female, about 30, come now, weakness in one arm, okay, and has history of migraine. Put your
Migraine.
differential weakness, and this weakness reversible or improve. Huh.
Hemiplegic
Differential,
migraine.
hemiplegic migraine, number 1. Number 2,
Stroke.
could be stroke, but now it is reversible. You didn't find any focal neurology. You should rule out by CT, non-contrast CT. What else? TIA. Suppose she has, you must ask
Yeah,
about thrombophilia. Business favorite, A+.
yeah.
A+.
That's Apla.
Anti-phospholipid syndrome. Any abortion? 3 abortion the
Recurrent
first trimester. Yes, we win exactly. A+. Okay, any blood clot before? And then you do
Correct.
the 3 markers for the A+. Give me the 3 markers for the A+, please.
I'm not getting this. This is cardiolipin.
Anti-cardiolipin, anti-lupus, anticoagulant, anti-beta-2,
Anti-beta
anti-beta-2
2.
glycoprotein. These 3. In one
Yeah,
shot, say like this. A+ business
Okay.
favorite. What else? BNH. Any dark urine in the morning?
Urine.
Yes or no?
Correct.
What else?
CD50.
Any OCB, long haul flight. Okay, BSIT, any mouth sores, painful
Any
sores,
mouth sores.
private painful sores.
Sores.
Yes. Ask about the most common 3 or 4. Very sufficient. Okay. This is FTIA in young female thrombophilia. Any sickle, blood disease, recurrent blood transfusion or painful crisis, very common in bases. This is the TIA. What else?
Yeah.
Hypoglycemia. Did you measure your blood sugar? Yes or
hypoglycemia.
yes?
Yes.
What else? Any epilepsy? Okay, before this headache, do you have any abnormal smell or abnormal sensation? Any epilepsy? Number 5, MS. You should ask
MS,
about
okay.
it. Yes. Any worsening of symptom on hot bath?
What?
Okay. Hot bath, okay. Or any electric shock-like sensation on bending your neck? Okay.
Bending
For
the previous
sign,
neurological.
Hof sign, hermit sign.
Okay.
Yes, the hermit sign or Hof sign. Or any previous painful eye movement or loss of vision. Okay. Any loss of control of your water work. MS can be any balance issue, cerebellum. Okay. If you have any suspect any MS, jump to cerebellum. At least the finger nose this the adequacy. At least and the gate and the nystagmus. At least. Okay, this is a consultation. In neurology, to examine everything, staccato speech, tandem gait, this diadokinesia, but in consultation, sufficient finger nose, and this diadokinesia, gait, nystagmus. 1, 2 or 2 of these, or the 4 if you have time, if you suspect any cerebellum issue. Okay?
Gait, what will be there?
Gait, ask the patient to do to make the gait to see she have wide-based ataxic gait.
Wide-based ataxic, okay.
Yes, and if you find what wide-based ataxic, ask for tandem gait. Tandem,
okay.
Finger to heel or toe to heel. Okay. If you suspect any, and you know, in the neurology station, we have a statement: don't go or don't walk without making the patient walk. I mean, in any patient, hemiparesis, paraparesis, any patient with any, even in the cranial nerve example, you must ask at the end of the station, I'd like to examine the gait of the patient. Before you walk, the patient should walk. Okay? Don't forget this. So this is migraine. Other migraine can come with, but rarely, but in your center, yes, it can come. In the Gulf, it can come. Very important also this. With brain, migraine with brain stem aura. What this mean? You know the vertebrobasal artery. Okay? This vertebrobasal artery, if we have here TIA in the vertebrobasal artery, you can give you manifestation which is similar to Wallenberg syndrome. Can give vision issue, balance issue, cerebellar issue. Okay? This, if the patient has atherosclerosis, so it will be vertebrobasal insufficiency due to ischemia due atherosclerosis. If the patient have previous history of migraine or headache, so it is vasospasm, vasoconstriction, called brainstem aura. Okay, in this you will get migraine with brainstem aura, and the patient come with vision problem. For example, loss of vision, for and reversible. So the same can be brainstem aura, or can be for migraine with brainstem aura. Can come with balance issue, sensation issue on one side. Okay, any issue due to vertebropatellar ischemia, and the ischemia cause of is vasoconstriction, not TIA or not atherosclerosis. If old age, you can say atherosclerosis or ischemia. Okay. This is another the last type of headache, and this is rare, but you should know also. Polycythemia rubra vera. Give me about 3 or 4.
Yeah. Do you have any itching increase after any hot bath?
What else?
Headaches, plethora of the skin, redness.
Oh, very good. What still we have?
Blood pressure might be high.
Maybe, but yes, we need the following. Polycythemia rubra vera is a cause for clot formation, thrombophilia, can come with bad Chiari. So you should ask about also clot formation. Intermittent claudication in the leg also can make in the leg intermittent claudication. What's important too, very, very interesting thing, that iron deficiency anemia can occur with polycythemia due to hematemesis or blood loss from the stomach. Even he has polycythemia, but blood loss can occur and iron deficiency can occur at the same time due to hematemesis, occur because congestion of the gastropathy of the stomach. What else? AML, she can transform, or polycythemia can transform to leukemia. Okay, what else? Gout, uric acid high. Ask about the joint. What else? Bleeding tendency from the nose and tooth. This is the gold standard. Words and polycythemia rubra vera. Give me the diagnostic. Most important.
Hematocrit and hemoglobin levels, RBC levels.
Okay, more than. More than.
JAK mutations, obviously. More than 50.
Yes, and give me the gold treatment on the polycythemia.
Both have to be maintained less than 50 something, I remember. A venesection and hematocrit should be less than.
Yes, hematocrit is 45. Repeated venesection, hydroxyurea or aspirin. And if you need to know the new treatment, you can know also the new treatment, ruxolitinib, monoclonal antibody, JAK inhibitor.
Okay.
Okay, but the most important, the gold standard, repeated venesection to avoid thrombophilia, hydroxyurea and aspirin. Okay, ruxolitinib. This is the new treatment, JAK inhibitor. Sufficient to say this word. Very good. This polycythemia, but you will ask like this. Any, as you told, the itching after bath, headache. What else?
Headache.
Yes. Clots. Yes. And example, anemia, any weight loss of appetite, any joint pain, and uric acid measure. Yes. Any bleeding on toothbrush or from nose. This is the gold standard polycythemia. And jump to any myeloproliferative, you should jump to
night sweats, fever, weight loss.
No, I mean examination. Splenomegaly.
Okay.
Yes, Dr. Danish, take this rule. Any patient with anemia, I mean fatigue. Any patient with fever. Any patient with weight loss. This combo or this triad usually come with each other. He will tell you, I have fever and I have weight loss and I have fatigue. This triad jump to two things in the examination. Lymph node, splenomegaly. Lymph node for lymphoma.
Lymphomas.
Okay. Splenomegaly. Yes, myeloproliferative and lymphoproliferative. Lymphoproliferative and myeloproliferative. Okay. Understandable? Lymph node and splenomegaly. In the lymph node, in the abdomen station, if you didn't examine the lymph node, it is a disaster. At least the cervical, take your time, 1 minute. Okay,
Hmm.
and then ask for auxiliary because you may find the patient has a lymph node or
lymph-
yes. And in the consultation, if you do in the anemia case, fever case, weight loss case, if you don't examine the lymph node or splenomegaly, they will cut your mark unsatisfactory. Even splenomegaly, that can take 10 to 20 seconds, no more. Just
Hmm.
lymph node, take your time, 1 minute at least, or يعني half to 1 minute in the cervical, then ask axillary. Because this deserve actually to examine the lymph node in the abdomen, and in this case with fever or lymph node or weight loss. Okay? Don't forget about this. Lymph node, spleen. Okay? In these scenarios, either in consultation or and in the abdomen case also. Okay?
Okay, doctor.
So this is the headache approach and the possibility. Either the chronic headache, okay, and the possibility, especially the migraine, and we called about complex migraine take care. And the medication overuse, doctor, we have still phychromycin. Medication overuse by exclusion. How
By
you can treat this
exclusion?
patient? Yes, how you can treat?
Basically, we can stop the simple analgesics and NSAIDs abruptly. But if it is
And
opioids, we should stop them like gradually, like reducing the
yes,
dose.
gradually. Okay, very good. And if he has any severe headache, you can replace by something called the rescue therapy, amitriptyline, for example, or anti-epileptic, and if the pain is very severe. No need to know this. طيب, pheochromocytoma also come with intermittent or recurrent headache.
Intermittent
طيب,
headaches, up and down BP, liable BP,
yes, I
palpitations,
will.
sweating.
Okay, you will say for me now, give me the golden points of pheochromocytoma and basis if you suspect pheochromocytoma. What you are going to ask and examine.
How is his BP? How is his heart rate, sweating,
Very good.
pulse rate, and
Okay.
the
Okay.
men syndrome, men, men 2A.
They are waiting for the syndrome. You told one. Number one, men.
Men.
Which men?
Men 2A, 2B.
2A mainly. Okay, type. What else? We have still two syndromes.
What else? Our neurofibromatosis, correct.
We have this still one.
Von Hippel-Lindau.
Yes, Lindo. Type. Take by one. Neurofibromatosis. Easy to diagnose. Give me the culprit diagnosis.
In NF1, NF2, neurocutaneous, all the swellings, hearing
Okay.
loss,
Okay.
capillary spots.
Here, sensory hearing loss in type 2. Okay. Central tumors, meningioma, and specific in type 2. Okay.
Type 2.
But here, axillary freckling. If you didn't examine the axillary freckling, they will minus you. Axillary and groin freckling. Neurofibromatosis in the skin. What else? Lesh nodule. Slit lamp.
Spots, leaf nodules in the eyes.
Lesh nodule in the iris. Okay. What else? Optic glioma. Fundus.
Okay.
Optic glioma. Skeletal system, sphenoid dysplasia. Family history. Cafe Olispot, as you said. Okay. This is Okay. This is a neurocutaneous. Negative. I am not neurofibromatosis type 1 doctor. Any sensory hearing loss? No. Any specific lesion headache? No. So
No.
I am not 1 or 2. Go.
Okay.
Finish. I want to go to Von Hippel-Lindau. Give me the 3 or the 4 points, or you should exclude Von Hippel-Lindau.
No, maybe bleeding through nose. Not remembering.
Not. This patient has bilateral, mainly bilateral renal cell carcinoma familial. He will say to you, my father. Yes. Oh, yes. Bilateral renal cell carcinoma familial. Number one. Number two, in the brain and in the eye, they have angiosarcoma. So can bleeding occur in the eye, can come with vision, decreased visual acuity. In the brain, you ask everything, any fits before, any headache, no doctor. Any vision, decreased visual acuity, yes doctor, or no. But the most important, family history of kidney disease, family history of kidney cancer. And even the patient, you can find himself, he make nephrectomy for renal cell carcinoma. Okay? So this syndromal men, still we have men 2A.
Hypercalcemia features.
Okay,
in CT.
very good.
So
Hypercalcemia.
basically,
What
yeah,
else?
polyuria, stones, depression, constipation.
Yes. Yes, drink water more than usual. Pass motor more than usual. Acid brush, fatigue, bone pain,
Yeah,
and sufficient, and constipation, hard stool. Thyroid,
correct.
medullary
Yeah,
carcinoma, family history of
and
cancer, the thyroid, or removed the cancer before.
swelling over the
And
neck.
number
Yeah.
3, pheochromocytoma. Okay?
Good.
طيب,
Yes.
give me the culprit if you suspect pheochromocytoma. Sometimes come with headache, and more frequent come with hypertension.
Hypertension. Yeah.
Hypertension, secondary hypertension. Give me the culprit diagnostic in the judgment.
So catecholamines, measuring urinary catecholamines, MIBG scan.
Plasma and 24 urinary, both plasma and catecholamine.
24 hours.
Yes, 24 urinary and plasma also. Plasma is more sensitive. Catecholamines, metanephrine. Okay. طيب. What else? How to localize imaging?
MIBG.
This is not number 1. This is number 3. Number 1, do the CT adrenal. You may find the mass. CT adrenal.
Correct.
If you don't find, you can do either PET scan or MIBG, dynamic MIBG.
Correct.
Okay. But the gold standard, do the simple one, not dynamic. If you need dynamic, do the MIBG or PET scan. But first, do CT adrenal. You will find the tumor. Okay. Then you will, as you know, phenoxybenzamine, alpha blocker. Then surgery to remove the adenoma. Say like this words, not sentence. I'd like, and also Dr. Dinish, when you said the judgment in the investigation, say number 1, I'd like to confirm my diagnosis. Apart from the basic investigation, I'd like to confirm my diagnosis. For example, in the subarachnoid hemorrhage, we have, apart from the basic investigation, I'd like to confirm my diagnosis by doing urgent CT on the brain, followed by MRI, and then lumbar puncture and MRA, like this. The other secondary, okay, not important, but here it will take satisfactory, because in their calibration, they write like this, in one sentence. If we have in the, for example, in the MIN2, we have association. So, number 1, apart from my basic investigation, I'd like to confirm pheochromocytoma by doing the plasma and the 24-hour urinary catecholamines and the metanephrine and the catecholamines. And I'd like to localize the tumor by doing CT adrenal, and if negative, I can do also MIBG or PET scan. Number 2, for complication and association, I'd like to do the calcium, okay, and the ultrasound and the BTH and the bone profile for the BTH, parathyroid hormone. Okay, for the thyroid, I'd like to do the thyroid ultrasound and genetic studies. Like this, first to confirm my diagnosis, second to complication and association. Everything like this. Everything apart from basic, I'd like to confirm my diagnosis by doing tick. And I'd like to do for the association and combination like that. Okay, examiner will respect you and raise the head for you because you are systematic and you know what you are saying and how you can deal with the patient in a systematic and organized manner. First, apart from basic, I'd like to confirm by doing the lab and the imaging. Then I'd like to search for association and complication. Okay? This is regarding all possibilities, nothing like this. But basis favorite, as we said, in sequence. In sequence, what? The Brest syndrome and subarachnoid hemorrhage, pituitary apoplexy, this is viral, very common now in the centers. And this urgent, you should say it as we have. If you come with intermittent pheochromocytoma, also the syndromal, they love it very much. Okay, if come with also hemiplegic migraine, complex migraine, very common like this. The other ICT, increase in the cranial tension headache, very common. We missed the one here, very important. Very important. In the chronic headache, you missed Dr. Dinish.
Obstructive sleep apnea. Okay.
Yes. You have this patient, morning headache. Okay, morning possibility. Headache. Okay, we will come to this to finish the headache and enter something else. Morning headache. Yes, doctor, I have headache. In the morning since 2 months.
In the morning, snoring, yes. Any problem with any excess during the day? Weight gain?
before you go to the OSSA, you should rule out first ICT. Ask if it increased by intracranial temperature or not. If
True.
no,
Any
so it is not
increase-
pituitary, no specifying, no IIH. So you will go to the OSSA straight. Okay, OSSA, the question, as you said, any snoring, anyone told you that a snoring at night, unrefreshed sleep, intimate relationship, immediately
Sleeping.
here finish what? At the same point, don't wait, driving.
Got it. Driving, yeah.
Yes, immediately jump to the driving. Okay, stop driving. Here, very important. When you find the snoring, unrefreshed sleep, erectile dysfunction, yes, then we have the seeds. You confirm the diagnosis. Then we need two things: complication. Okay,
Complications.
what is the complication and the cause? First the
Causes,
cause and
yeah.
then complication. Cause, weight gain,
Weight gain.
jump. You will one by one. Do you have any stretch
Pushing
mark
back
on the abdomen? Stretch mark on the
Mhm.
abdomen? No, doctor. Okay. Do you have any weather preference? Or
Hypothyroid.
no, doctor. Do you have any
Acromegaly.
abnormal hair growth or pituitary or period issue?
Metabolic syndrome. PCOS, yeah.
Polycystic ovary. Polycystic ovary. Do you have a change in shape of your
Acromegaly.
Yes,
And
acromegaly. Finished. Nothing. Do you have any hypoglycemia period? I mean handshakes, sweating for insulinoma. Okay, men one. No, doctor.
men, okay.
I have no any cause of obesity. Equals either metabolic syndrome if she has any pre-diabetes or pre-hypertension. Borderline 100, everything 100, blood sugar and the blood pressure 140. Okay, not yeah, pre-hypertension and pre-diabetes, metabolic syndrome. Immediately jump to measure. What you are going to
Waist.
measure?
Waist.
Yes. In the male, 102. In the female, 88 centimeter with circumference. The second
88.
jump, yes, second jump to the neck circumference.
Neck.
Okay,
18.
about 17 or yes, 17 inch. Okay, 42 or 43 centi. Yeah, I like this. To see, or I say it like this: I'd like to measure the waist circumference. I'd like to measure the neck circumference. This is for the cause, for the complication of OSSA. Give me what you are going to examine.
Complications can be carpal tunnel.
Yes,
No.
very good. We have three complications in any obesity: carpal tunnel syndrome, osteoarthritis, and OSSA. These are the three of any obesity. We have this three triad in any obesity. But we have pulmonary hypertension, systemic hypertension, stroke. These are the specific complication for the OSSA. Yes, pulmonary hypertension must palpable V2, loud V2, must. Okay, JVB. Okay. Then give me the treatment of the OSSA.
Treatment: weight loss, the central treatment, and modafinil and mandibular devices, CPAP.
The most important, yes, the most important CPAP, yes, weight reduction. Modafinil can be added, yes, but weight reduction is most important. And surgery, either bariatric or uvulopalatopharyngoplasty. Okay. And before this, stop
Smoking.
driving. Smoking for sure. Driving is most important for the safety. CPAP, say it number one. Okay. Not modafinil number one. Modafinil supported, not essential. Okay. This also if the headache is chronic morning headache. The CO poisoning, yes, CO poisoning not common now. If she other one in the family and improved when she away from the vapor, not common, but you should this morning. One time also appear a very malignant scenario, but you should know. But it will not come, I am sure. But you will just morning headache. This is the last one of the morning headache. And the patient who examine her or him, you find she is 40 years, taking metformin for recently diagnosed type 2 diabetes. Her blood sugar A1C is uncontrolled totally, about 9. Okay, with metformin about 1 or 2 grams per day. And when you see open the chest, you find a nice scar here, median sternotomy scar. Was this surgery for the lady? They said to you, I don't know. Actually, they did for me a surgery while 10 years back. You know this scenario?
No,
This
no.
one, the most malignant scenario appeared in this. Actually, this case is very difficult. This scar for thymectomy, because this patient has weakness, and this weakness make bulbar manifestation, make CO2 retention. CO2 retention make chronic headache in the morning. This is the cause of bulbar manifestation of myasthenia gravis. The cause of myasthenia gravis is immune. She has type 1 diabetes, but diagnosed as type 2 and take metformin. And now her blood sugar is uncontrolled. So it is type, and she needs insulin. Okay? It may be also autoimmune polyglandular syndrome type 2. This is a very tricky scenario, very tricky appeared because she is borderline age. Her age is 40, can be type 1 and type 2. She was diagnosed first by type 2 and given metformin, but A1C is 9. So, and she has thymectomy for myasthenia, very complex scenario. So most likely, you should do the anti-islet antibody, anti-insulin antibody to confirm the type 1 diabetes. Okay?
OPS.
It's very rare to appear, but just to know. This appeared one time, I think, in UK, and very malignant scenario. But the usual, as we said, spaces-wise, don't enter except, as we said about subarachnoid. Don't enter except to said pituitary apoplexy. Don't enter except rest وhypertensive neuropathy meningitis. This is the acute. And the chronic migraine complex, very important. Migraine complex or hemiplegic membrane and the medullary or brain stem migraine. Okay. And ICT, pituitary, YIH. Okay. And OSA. And in the list, medication of use or tension and tension. Okay. This is the map in your brain. You will sort out when you enter, jump and rapidly, very fast sort out your pathway. Is it acute or chronic or recurrent? And the acute, she has any pituitary issue? No. Any raised intracranial tension? Any what? Any ADPKD or subarachnoid? Any raised blood pressure? Everyone, yes or no? To just put the differential. Is she has anything tacrolimus? For is she has any amlodipine and not take for any breast syndrome? Okay, compliant. Like this. Nothing jump to the other. ICT raised or not, it has pituitary issue. No pituitary issue, it has any acne or obesity. Okay. And then if you have the chronic headache, you will find and no ICT. You'll go to the OSA. And if OSA negative, you can go to yes, tension and the medication use. Okay. Intermittent also don't forget about pheochromocytoma, especially syndrome. Okay, this is about headache. Now we will shift to another topic. Okay, Dr. Danish. Just let's stop the